So anterior hip replacement has been an incredible procedure. The operation of the century. I mean, it is an amazing procedure. It is fully restorative for people's lives. But it's so variable in the cost. There are some places where it's under $20,000 and some places well over $150,000. It makes no sense. We have a large demographic of patients, the baby boom population that's coming into age needing joint replacement surgery. And we don't have enough surgeons right now to accommodate that need. How do we apply all these wonderful advances and be able to expand them across larger populations? By increasing the number of trainees and fellows that have the skill sets needed to provide that care, we are going to be able to effectively deal with that need. What we've found is that one of the most effective ways of promoting or improving the access to education has been through private philanthropy. If you look at the large health systems in this world, the Mayo Clinic, the Rothman Institute, they couldn't have existed without the marriage of quality outcomes and private philanthropy. That's what this is all about. Getting the stakeholders, the people that have benefited from the technological advances and the people that can promote and teach it together in the same room to talk about how can we create something bigger than ourselves. Education and mentorship is about creating a bridge between generations of surgeons. It's about taking an educational morsel, a morsel of information, and taking it from one generation to the next. And without a continuity of training, you can't get there. And that's what this is about. It's about passing those important pieces of information from one generation of surgeons to the next.
That's sort of your duty. You know, the Hippocratic Oath, one of the things is you don't keep information from other physicians. You share what you know, the good and the bad. And in fact, really, the bad is what you really want to share because that's what tends to reduce the risk you're going to get in trouble with somebody else. And a fellowship is probably the best way to do that because you really see challenging patients.
I think the anterior approach is one of the reasons why outpatient arthroplasty has really taken off. Similarly, I see similar parallels in what's happening in the knee area with Dr. Howell. Calipered kinematically aligned knee surgery has reduced the postoperative care needs in terms of physical therapy, reduced the pain management challenges associated with postoperative management, and it's really made a more reproducible model for outpatient knee arthroplasty in this country. And I think it offers to serve as a similar exciting field for knee surgeons the same way that direct anterior was for hip surgeons a decade ago.
So Dr. Mast and I are sharing, well, probably 20 years. He's a little younger than me, but for me, it's almost 35, 40 years of practice.
And when I look back on my formative years, and I look back at when I completed my training and I went and I developed a mentorship relationship with Dr. Matta, Dr. Gons, Dr. Lode, Dr. Leunig, I had this incredible feeling like I had a chance to work with the world's best, and it gave me such confidence in tackling problems in my own practice.
And it's that type of thing, that experience that you try to give to a fellow in a short period of time of 1 year, so they don't spend their first 5 or 10 years of their career going through what it took you to learn in your lifetime.
So when I talked to Steve Howell about this, I mean, both of us have this same sort of belief that this has to go out. The gospel that we have been trained in has to be shouted from the mountaintop. And the best way to do that was a fellowship. And to get this information into the hands of that next generation, we want what we have learned about how to improve care, how to improve access, how to improve value. These are all important concepts, and it's going to be what this fellowship's all about.
They're not only going to learn how to operate, they're going to learn how to handle the patient in the office, they'll learn how to evaluate them, and then they're going to learn how to organize their thoughts to create an abstract and then a presentation and help do the data analysis and then write papers, because those are the archives that we use to build the building blocks, if you will, to build a better knee replacement.
The access to care piece is hard because we're already in a problem with access in this country. Early on, I did charitable care through Hipster. The idea was direct funding to Hipster, the foundation, allowed me to take care of people. And the problem is that it was limited. The cost of care in this country was so large that the number of people that I could actually influence by the Hipster Foundation and all the generosity of the donors was actually very small. And so where I felt that the best use of the contribution was for education, because at least that way I'm creating surgeons that are going to be able to provide a very high value level of care. But not only that, by virtue of things like fellow clinics or supervised education, that I can impact access by virtue of the fact that there are patients who are going to need care, and there are surgeons who want the educational benefit of being involved in care. That relationship is a sustainable model for improving access. You have to remember that every one of us, every surgeon out there was at once a trainee. And I was a damn good trainee, and I provided a lot of good care to people. And that's important to remember. You can't know where you're going without knowing where you are. I mean, it's basic stuff. If you don't know where you're starting, you don't know where you're going. And the data project is all about capturing data so we know where we are. And the best way to try to distill, down to the best way to do things is to know what's working. And the data project that we're working on right now that's the pinnacle of it. I mean, knowing what's working and being able to identify how to best apply techniques and technologies to achieve those outcomes in a cost-effective manner. That's the future of what we're doing. We're showing the clinical picture with the data set right now, but we do have data that was gleaned from the cost side of the analysis. And the marriage of the cost analysis and the clinical data set is what's going to give the big picture on value, right? Because what we learned is while the surrogate marker for quality is cost, that doesn't always give the full picture. You want to make sure that your clinical result is excellent as well. And so the marriage of the two data is what we're looking for here. The data project is about identifying the best practices, but then being able to relay that via publication, via medical education, getting it into that next generation's hands and letting them run with it.